We'll move on to Rafa's second case. Looks like the audio has sorted itself out, which is great. There has been some volcanic activity around Rafa, which has interfered with his internet and the audio, but it looks like it's sorted. So Rafa, please tell us about your second case.
Thank you very much, Arlene. This is a 22 years old man, Mexico City resident, no joke, because he is a very sick patient. It started in April 2017 with weight loss, progressive increased abdominal volume, hepatomegaly, massive splenomegaly, and ascites in ECOG 3. Patient was referred to the NIH hospital with Dr. Tuna in October 2017. And the diagnosis of CML, Philadelphia positive, was until November 13. The cytogenetics was not only the Philadelphia chromosome, but also 4 different fusion patterns, compromising the chromosome 4, 888, and 16. The autos was classified as high risk with 135 points. Fortunately, the patient lost the follow-up until May, until August 2019 in accelerated phase. So in August 2019, patient started imatinib 600 milligram with us and developed grade 4 and ascites, no hematological remission, and also thrombocytopenia, and owned to dose reduction to 400 milligram. And in January 2022, mutation E450G was detected, and continue the treatment, but we had to switch to bosutinib 400 milligram daily because patient doesn't have any molecular response. So recently, recently the patient had a blastic phase myeloid and accepted to asciminib and azacitidine. I think I haven't. For discussion, I think the primary care referral on time, we must to insist and emphasize with other medical doctors. Also improving adherence. We have seen in this case maybe the natural history of CML pH positive with clonal evolution, and also intolerance and development of blastic phase, and really treatment challenge.
I think the big unfortunate part of this case is that 2-year window in the beginning after he was diagnosed when he didn't have any kind of intervention. I mean, you certainly have to question how that has impacted all of the rest of this, because that obviously just allowed for some significant clonal evolution, like you said, just the natural history of progression of his disease. So yes, of course you can control CML that is, diagnosed as de novo accelerated phase disease, but in his case, but it is more challenging, and his case is showing that. So I think it's unfortunate that he went those 2 years without any kind of intervention.
Yeah, I think quite often probably the typical 22-year-old, maybe I would say, and it's hard. And adolescent age like that is always a challenge for adherence. I think as soon as they improve some, they stop the drugs or they take them infrequently. And I mean, missing 3 pills a month probably is enough for them to not meet eventual milestones. So because 90% adherence looks achievable, but if you say 90% is in a month, 10% is 3 days a month. So that's 3 pills. Missing 3 pills is enough to probably not meet the later milestones. And especially somebody who started off as a high-risk disease, had alternate pathways of resistance, even a diagnosis. I think those are very worrisome features. And unfortunately, with his age, he probably did not keep up with his medications and appointments. But hopefully, I think this is again somebody who I think we would look at transplant. One, because he's transformed to blast phase, but I've had discussions elsewhere where people said that if they're non-adherent to TKIs for whatever reason, should we transplant them? I think that's an interesting question or a discussion. But I think that's still unanswered. There is no data there. That's just up for discussion.
And I'm curious, was ponatinib considered when he progressed to blast phase, and if not, how come?
We have no access to this drug. Sorry.
Oh, okay. And then the asciminib azacitidine, that's a clinical trial?
Yeah, she's this patient is with the Dr. Tuna in the NIH hospital in the single case with asciminib, and see what is happening with azacitidine combination. We are not sure. We are looking for in the literature what is the experience for other people in this phase, particularly in this case, which I think is a very important challenge because he has a lot of chromosomal changes. Maybe some had to see with the Philadelphia chromosome and others not. So I think it's a kind of dual treatment, some with CML and others for the other, to the other leukemia maybe. So after 1 week, I saw the patient last week, 1 week ago, and he had a splenomegaly 22 centimeters below the lower abdominal. Today he's 16. Yesterday the patient is 16, only with asciminib.
Wow.
And the hemoglobin and was grade 1 anemia and not thrombocytopenia, and the leukocyte count is 23,000. So then I think the response will be unpredictable. So the question is, what about the experience that everybody has with this kind of patients in blastic transformations with many chromosomal changes? I don't know, asciminib has been associated with other, like azacitidine or maybe cytosar, anthracyclines. I don't know. I'm just looking for some of your recommendations, please.
I've only used asciminib in a blast phase patient once, I think. Once that I can remember off the top of my head. And I used it in combination with azacitidine and venetoclax. So obviously off-label everything. And it was probably 4th line for myeloid blast phase. And it actually, she got back to chronic phase for a short period of time, but not long enough to be able to get her to transplant. We were about to get her to transplant, and then she relapsed again. But this is, in your case, obviously the first line of treatment for advanced phase or for blast phase CML. So I think there's something to be said for that. And if there's a donor search ongoing at the same time and he could make it to transplant as soon as he's back in chronic phase, or as long as you can get him there, then I think there's certainly the potential for some success here. I think it's a very reasonable thing to do. I think
the question is indications for the bone marrow transplantations during the blastic phase in this patient. We think is not exactly indicated until maybe we will have some kind of remission if we have. I don't know, what do you think?
Yeah, certainly agree. I think without at least back into chronic phase or close to that, they don't do well. And transplant, certainly most people in the blast phases, when they responded, even those who responded, the duration of response seems to be about a year. They start taking off post a year without any of these additional chromosomal changes that this person has. People take about a year. That's the median duration of response, about 12 months to 15 months. But with these additional mutations or chromosomal changes, I would worry that it will be shorter than that if he gets into remission. If he doesn't get into remission, I think there is always a chance of he's young and probably in otherwise good health. there is always the chance of using traditional induction as well in combination, and try and see if we can get into some remission.
Soledad, you're waiting patiently. Sorry, Rafa. Soledad?
I say thank you. I say thank you for
I'm
the
sorry. I'm sorry. I was asking if maybe he's so young that even though he doesn't have a good adherence, compliance with the drugs, the option was at first to go to transplant, but now that he's in a blastic crisis, well, of course, I would think to take him to remission first, and then proceed to the transplant.
Katia?
Yes, a question for Vamsi and Kendra. If in case this patient goes to transplant, for how long would you maintain asciminib for maintenance after transplantation?
So I don't know, please correct me if anyone knows that there's better data to support what I'm about to say. But as far as I know, I'm kind of making this up just from my own experiences. But I tend to try, whenever possible, in a blast phase patient to continue maintenance for about 5 years post-transplant, if possible, if patients can tolerate it. Obviously, that can be hard sometimes with GVHD and other complications. And so it really depends on the patient, but that's kind of my goal. And then in an accelerated phase patient, I try for at least 2 years. Again, what that's based on, not much, and it can be hard. I mean, some people do beautifully and other people, it's a real struggle, but I certainly feel better if we have to stop it, as long as the patient is off of immunosuppression. So I really push to keep them on if they're still on immunosuppression. But once they're off, I certainly feel better about stopping a TKI if we have to, just because they'll get a little more of that GVL effect, hopefully. I don't know, Vamsi, if you have something completely different, or if
no, I was actually going to answer first and say that that's an easy question. Let Kendra answer that, but you took it.
Throw me under the bus to just make stuff up.
Because I agree with you. There is really no prospective data on transformed patients, because a lot of that is from literature and single institution or cooperative group retrospective studies. And as you say, people have used between 2 to 5 years, but the challenge is always combining with other medications and tolerating them through the 2 years. I think it's easier after the first 6 months, because the first 6 months they're on multiple medications, but it's getting them through that time. So it's always a challenge to get them through that 2 to 5 years timeline to use that.
Thanks.
Such a great discussion. And unfortunately, we need to move on.